But the world is full of optimists. So one of the jobs of the statistician is to rein in the enthusiasm of the cardiologist.
Welcome to Season 2 of the sOOPR podcast. In these conversations, we're bringing you even more insights from successful fellows and advice from leaders from across the UK research landscape. I'm Nikhil Alawalia, and this is brought to you by the British Junior Cardiologists Association in partnership with the BHF CRC. If you like these videos, please subscribe to our YouTube channel and leave your comments below.
I'm really pleased to be joined by Professor Stuart Pocock, who's a Professor of Medical Statistics at the London School of Hygiene and Tropical Medicine. He's worked in the field for 3 decades and produced some incredibly valuable work, and his primary research interests are clinical trials, both as regards to the methodological developments of them and also applied collaboration in them. He's made important contributions to the medical field, especially in the area of cardiology, and serves as a statistical member on many trials, data monitoring and steering committees. So Professor Pocock, welcome, and thank you so much for giving up your time.
My pleasure.
Great. So the question I ask speakers first is to tell us perhaps a little bit about their journey to where they are today, in particular focusing on your early entry into PhD work or research work when you were a younger academic.
Well, I started out doing a maths degree, so who knows where that would take me into medical applications. Then I got interested in statistics as I saw a route to real-world applications, and then realized the most interesting applications of statistics seem to be in medicine. I worked in a variety of medical areas: occupational health, environmental issues, risk factors in cardiology, in general population cardiology, but my focus eventually around the 1970s and early 80s into clinical trials, and more by a random walk of opportunities than natural desire. It ended up mainly being in cardiology applications.
Over that time period, you've been involved in research all the way through. How do you think studies and how these clinical trials are designed has changed? What do you think are the major things that are different today as opposed to when back in the 80s?
Well, really a lot more rigor. I think we now realize that for major new interventions, whether they be drugs, devices, or strategy trials, that we really needed better quality data, and we also needed larger studies. One reason for being in cardiology is because it's a very collaborative profession. And so cardiologists talk to one another, they have enthusiasm to get things done. And therefore, I think the quality and size is the main things that have improved. And so statistical standards, publication standards have improved over the decades as well.
So talking of collaboration, what do you think is the ideal paradigm for a cardiologist who's doing clinical studies, as in how and when should they liaise with a statistician or a medical statistics department?
Ideally from the start, though I think any clinical trial, you go through a process of first trying to define roughly what it is you're trying to do. What are the treatments? So firstly, what are the patients? What are the treatments? What are the outcome measures you might use? Get some sort of feel of all that, perhaps before you approach the statistician. So at least you have an outline synopsis of a protocol to be working on. Also, I think the young cardiologists would benefit from collaborating with more senior cardiologists. So I think it's good that the young cardiologist looks to opportunities to join in multi-center, multinational trials where they learn from their seniors in cardiology what it's all about. Like the seniors like to being cynical for a moment, the seniors like to pontificate, they like to talk, then they need some doers in cardiology who actually do the work.
And how much background statistical knowledge do you think the trainee needs if they are collaborating with a medical statistician?
There's a one-word answer, which is more than they have at present, usually, because statistics is hated when you're in medical school. It's often not very well taught when you're in medical school. And so I think there should be pathways for some more rigorous training in statistics once fellows are actually getting into research, and they should perhaps attend short courses, look for other ways of expanding their knowledge. It depends what they intend to do in their career. If they see they're going to be a serious researcher over many years, involved in databases, I think they really need quite a firm statistical knowledge. And I have one or two fellows I'm working with at the moment in Spain who have undertaken master's courses in research methods, either statistics or epidemiology. So they've really souped up their ability, and they can do some of their own analyses. So I think it's well worth getting a deeper understanding if you see your research pathway being in databases such as trial data.
So just building on that then, what do you make from your perspective of the standard of statistical analysis in sort of modern cardiology literature?
It depends which types of studies you're looking at. If you're looking at the major trials that are likely to reach the general medical journals that we all want to get into, such as the New England Journal, JAMA, the Lancet, maybe BMJ, then I think those trials, generally speaking, the standards of quality of analysis is quite. But the reason that's happened is the recognition you need to document in advance a statistical analysis plan, in addition to your protocol, which specifies how you're going to analyze the data and with what priorities you're going to study different types of analyses, with an underlying desire to control what's called the type 1 error, the risk of a false positive result. And the major journals, including the major cardiology journals, are very good on that. And so authors know that, and therefore they improve their act to cope with that.
Great. So let's think about the early stages of trial design. I think the first couple of steps, once a cardiologist has got the idea and the patient group in mind, is to think about sample size and study design. How much of that needs to be really rigorously done from the start, and how much of it can be adaptive as you go through and gather your information in the study?
A bit of both. I think one first needs to come up with a realistic sample size for a trial based on experience of previous trials that maybe others have done. What kind of treatment benefit is realistic to expect? And then statistical power calculations that will help you determine how many patients you need, followed of what severity of disease. So you want to study sufficiently seriously ill patients that they are going to have the outcomes of interest. And secondly, how long they need to be followed for to see these outcomes. But the world is full of optimists. Why not be optimistic and say, my treatment is going to be fantastic. It's going to halve mortality, say, which is usually unrealistic. And you can come up with quite a small trial if you're overly optimistic. So one of the jobs of the statistician is to rein in the enthusiasm of the cardiologists and maybe pharmaceutical companies if they're involved, to say you need to be realistic about the modest magnitude of effect that you can expect in many a trial. And then it means you're going to have to do larger studies than you might have wished.
Okay, and then moving forwards, what are your thoughts on interim analyses? And do you think that they should be incorporated into most studies, or do you think it should only be ones where the data needs to be assessed for safety reasons in the middle?
A trial of any size, I mean, if you're just doing a small trial while you're studying biomarker changes over a short period of time in a relatively small number of patients, then you may not need to do interim analyses. But the pivotal trials that are looking for real benefits in patients' long-term outcomes, they all need usually to have interim analyses organized with a separate data monitoring committee, who are the group that only see the unblinded results as the trial goes along. And those data monitoring committees mainly exist for patient safety. So you're looking if a treatment actually appears to be doing a new treatment, and then you may need to stop early for safety reasons. You could also consider stopping for futility if it turns out that a new treatment appears not to be an advance that you are hoping for. Then why waste lots of resources by pursuing a negative conclusion to the bitter end, and you could stop a futility. It's more challenging to decide when to stop for evidence of superiority of your new treatment. And there is generally thought that you need overwhelming evidence of superiority. The phrase proof beyond reasonable doubt that a new treatment is superior is often used. And then, so you set up these guidelines for how a data monitoring committee should look at interim results. And I've served on many of those data monitoring committees over the years. It's an ethical challenge. It involves a lot of statistics, involves a lot of practical organization, but you're underlyingly thinking of ethically what's the best thing to do. And the ethical issue is quite complicated because you're juggling between individual ethics. Is it right that the next patient should be randomized to either treatment in the trial? And also collective ethics. Do we know the answer from this trial sufficient for what society's needs are for future patients? So the interests of the patient in the here and now versus the long run of a much larger group of future patients is the ethical challenge underlying all interim analyses, what to do.
Okay, so then thinking about trial design, the randomized controlled trial is really the gold standard of reaching results, but a lot of fellows, because of the time span of a PhD project, plus also capabilities, may choose to do some observational cohort work or retrospective analysis. Do you think there are examples where that sort of research has been incredibly valuable?
Yes, the trouble with observational research, if it's comparing different treatments, then there may be a selection bias of which patients get which treatments. So you have a new treatment, then that might totally change. A new treatment at the time in the observational registry, that might change the selection of who gets the new treatment and who does not, compared with those who got other more standard treatments. So lack of randomization always means there's a potential bias. There are ways of trying to adjust for that bias. There are techniques called propensity scores for adjusting for the different patient profiles in different treatment groups. But there's always unmeasured confounders, things that might influence the choice that you haven't recorded. And so for evaluating the efficacy of treatments, generally observational research has its limitations. Take COVID research, to deviate from cardiology for a moment. It was much easier to rapidly do observational studies of new COVID treatments, most of which turned out to be pretty useless in coming to terms as to whether a treatment really worked or not. The biases were too great. A good place for observational research is studying safety issues, because often the randomized trials are not large enough to identify rare but really important safety issues. And then observational data based on large, routinely collected registries may be important in detecting safety issues. And there's a whole profession called pharmacoepidemiology, which is pursuing drug safety. And so then it has an important role. But looking at observational databases is an opportunity for fellows to get well practiced in looking at treatment patterns, looking at outcomes. So it can be a valuable training ground for fellows, but need to recognize the biases.
So then thinking about your outcomes, how much weight should be put on a single primary outcome measure versus keeping that open and having secondary and alternative outcomes in a study design?
Good question. It could be a complicated, rambling answer, so I'll try to be brief. I think firstly, if you're heading towards a major medical journal for your results, or to the regulators such as the FDA and EMA, they will usually expect you to have chosen a single primary outcome measure. It could be a composite of different disease entities. It could be a composite of mortality and serious non-fatal events in cardiac outcomes. The most common one across cardiology is cardiovascular death, myocardial infarction, or stroke, whichever happens first in a patient. And then the journals and the regulators wish to say you can study secondary outcomes, but you really need to pass the test of the primary outcome being significantly positive before you then look at those secondary outcomes. That's the rigor of the journals and the regulators, but sometimes it's a terrible straitjacket. I've been involved in trials of PCI versus CABG in a variety of patient groups, say in left main disease, where a single primary composite outcome doesn't capture well what's going on. You can have procedural MIs, which can be more common in bypass surgery. You can have spontaneous MIs that occur later that are more common in PCI. You can have a higher risk of stroke in CABG. You may increase mortality risk later in PCI. And so to try and put all that in one composite outcome, it doesn't capture everything that's going on. So I think you have to play the game of the rigor of the journals and the regulators. But at the same time, you need to be creative, you need to be flexible without cheating by looking at all the secondary outcomes as well. Like quality of life will usually be a secondary outcome in most trials. But in a trial of bypass surgery, we know that there's a deterioration in quality of life in the short term, whereas PCI, their quality of life is preserved better in the short term. So you're juggling with all sorts of things, short-term outcomes, long-term outcomes. So we're forced into a single composite primary outcome usually, but don't lose your creativity in looking beyond that in how you personally interpret a clinical trial.
Yeah. So then coming to this idea of composite outcomes, what's your opinion on designing composite outcomes? Because, in an ideal world, we'd pick hard endpoints, which mattered the most. So death and CV events. But because I guess we're doing so well in some ways in cardiology and medicine, a lot of people tend to combine more common endpoints into that composite final endpoint. Do you think that's the best possible option that we have, or do you think there are other ways around these issues?
Well, as prognosis improves, you do have to, in a disease area, you do have to look for a broader composite to stand any chance in a finite trial of showing a treatment difference. The trouble with a composite, which is time to first event, obviously the first event can be the least important, like a revascularization, say, is less important than an MI. Therefore, that has its limitations. I've done some work on putting a composite in a hierarchy, where you say death is most important, strokes maybe next, MI next, revascularization next, and then maybe improvement in quality of life might come next. And I invented a methodology called the win ratio, which is a hierarchical method for composite outcomes. And that's really catching on in the last 5 to 10 years as becoming a better way of handling composite outcomes. Can't say much more about the technicalities of that or we'll get bogged down, but it's a new way of getting away from the simple way of composite is time to first event. We can do better than that.
And then breaking down the research, you touched briefly on how it's worth looking at the secondary endpoints, perhaps the nuances of the data and the statistical significance of any results. Can you describe how you can use that information to develop further studies and potentially how much you can rely on that to design further work? Is that reasonable to do, or would you only be looking at those primary?
Yes, I've been consulting only this week on a potential new trial. It was a major trial in heart failure that had a borderline result. It was just about statistically significant on a very large study, and therefore it's questionable whether the magnitude of benefit is great enough for all patients. And so they're now saying, well, perhaps the real benefit would have been greater in higher risk patients, in patients with more advanced disease. And therefore, from the results of the first trial, then looking at the higher risk patients and defining a new trial, which would look at higher risk patients, where indeed the benefits may be greater and more clinically important.
Looking forwards with your experience, what do you see as the future for clinical trials, particularly thinking of a fellow who wants to go into this world? What advice would you have for them?
I think it'd be good if they looked for ways of getting involved in major trials. They obviously can't take the lead on them, but looking for a role in them as a trained young clinical cardiologist. And there are ways of doing that. There's the Cardiovascular Clinical Trials Forum, CVCT for short. People can apply to be recognized fellows wanting to work in clinical trials. One of my fellows only just applied this week, actually, or last week, I should say, to join that scheme. And they're looking, because otherwise you're having the aging guys like me getting too involved, or the cardiology equivalent of me, having all the fun of the major trials. And we need to generate a younger body of fellows who are coming through, who see their future in trials. And so I think you can apply to be involved in major trials, and there are routes to do that. Secondly, on your own institution, smaller trials, you can get involved too, and you may become, it's possible to become involved in national coordination of a global trial. So you could be the UK, you and your boss could become the UK coordinators of a global trial, and that's another pathway to get involved. So there are a number of ways it can happen.
So on that note, I just want to thank you again, Professor Pocock, for your time. Really grateful for all your insights and advice that you've given to trainees today. Thank you.
Thanks very much.
Join us next time on the podcast for...
I had that many no's and doors shut and, that this isn't the right time for you. But that just kind of drives you more.
I'm joined by Dr. Claire Lawson, who's an NIHR Advanced Fellow at the University of Leicester. We talk about going into academia from a nursing background, the importance of tenacity, and the advantages of multidisciplinary collaboration.